Like a multiverse or something.
Yeah, I like that.
A little weird. It took me a second, I was like, weird. Okay. All right, good afternoon. I get to teach you all today. I'm very excited to talk to you about, this is really gonna be sort of our beginning conversations about some orthopedic conditions. This is a little bit preview into your orthopedic practice course for fall, which is wild, right? All semester. So I teach the orthopedics course in the fall, and that's the assessment and intervention of orthopedic conditions. Today, we're going to talk about the pathophysiology of fractures and limb loss. I'm also going to come to you on Thursday. You're going to have me like 3 in a row. Thursday, I'll be here to talk about wounds and burns. And then on Tuesday, I'll be here for peripheral nerve injury. So a lot of really fun stuff to talk about. I brought you some glucose to keep your brains going. So if you're a chocolate fan, pass them around. Yeah, right. Let's go and your little afternoon pick me up. Okay, so there are two sort of parts of this lecture today. We're going to talk about fractures and bone healing first, and sort of the recovery process and OT's role in that. And then we're going to shift to limb loss or amputations and sort of talk about sort of basically the same things. With fractures, we're going to classify different types of fractures and how we, like the language that we use for medical management and OT rehabilitation. It sort of it really matters what bone was broken, how it was broken, what it looks like when it's done breaking, and you know how that relates to the healing, the bone healing, and the overall recovery process. And there's a lot of factors that go into that. And then we'll talk about OT's role in the phases of recovery, and we'll basically do the same thing for limb loss. Okay. So again, just to give you a quick overview of how this fits into orthopedic conditions. In your textbook, the chapter is orthopedic conditions, and then they talk about a few things in there, fractures being one, amputations being another. And we're also going to throw in a little bit about osteoarthritis today as well. We got like 2 slides, I think, and we're going to talk again more about that next semester. That leads to discussions and things around joint replacements, like hip replacements, knee replacements, shoulder replacements. We'll do a lot of that in ortho in the fall, assessment and intervention from that perspective. So orthopedic conditions, these are all the ones that we're really going to talk about in orthopedic in the fall. So here I have highlighted what we're talking about today. Thursday, I'm talking about burns and wounds. And then the next Tuesday, I'm talking about peripheral nerve conditions. Muscle injuries and tendon injuries also fall under orthopedic conditions. We're really saving those. Those are really very specialized, sort of protocol-based type of assessment and intervention. So we're going to leave those for the fall. You have enough that you're learning in this class. We can shift a little bit more to the fall. But the really important thing to know is orthopedic conditions are musculoskeletal conditions. They do not involve the central nervous system, right? So if you look at all these conditions, they're in the peripheral system, peripheral nervous system, or muscles and bones that are like outside of the spinal cord and outside of the head, basically. Now, people that have central nervous system diagnoses can also have orthopedic conditions for various reasons, but often people end up with orthopedic conditions without central nervous system diagnoses. So we're going to take that perspective of people who don't have other things going on and just orthopedic conditions. Okay, we're going to be playing on that. And just a really quick sort of review about, in general, if you are working with somebody with a new orthopedic condition, it's usually often somebody who doesn't have other challenging, and this processing challenges means not cognitive challenges, right? Somebody that, you may not be concerned around them being able to follow the directions or understand what it is that you're working on. You're typically using a restorative approach. Does anybody want to self-disclose if they've had a fracture in their life? Yep, I had 2. I broke my wrists. skiing in 7th grade and I broke my ankle in a soccer game in college. So I've had a couple. And right, it's a restorative approach. It's an acute injury. Acute meaning it happens all at once, all in one time, right? And then it heals. And there's like sort of this process of healing. And the goal is to return to prior function before that fracture happened. The younger you are, the more likely that is going to happen. Now we'll talk a little bit about fractures in the elderly. That's a little bit different. Those of you that have had a fracture, did you return to your prior level of function when you're fractured? Yeah. Right. Individuals that are seen by OT after having an orthopedic injury typically start in the acute early phase, and we follow them all the way through to returning to prior level of function. And depending on where they are in that recovery, what we're doing looks much different. Right. So if you have had a fracture, what was it like the day after your fracture? How much could you do? Not a lot. That sucker hurts. You're in a lot of pain. Every time you move, the pain gets worse. You probably can't put any weight on it. If it's a leg or an upper extremity, it's difficult to do absolutely everything. Right? And then as bone healing happens, pain reduces, you get more and more function back and you can move around. Okay, so what we do with people initially looks way different than what we're doing towards the end. Some conditions can become chronic, right? So if they're very complicated orthopedic injuries, or if there are other comorbidities or concomitant injuries. So concomitant means injuries that happen at the same time. Comorbidities means other diagnoses that the person already has. So an example of a concomitant injury is if you're in a motor vehicle accident and you end up with a femur fracture, but then also a head injury at the same time. That's concomitant. Comorbidity is if you're in a motor vehicle accident, you have a femur fracture, but you already had a diagnosis of diabetes. That's a comorbidity. Right? So it's a thing. So sometimes, based on different factors, orthopedic conditions can become chronic. And then we would really shift from a restorative approach when these become chronic, right, to maintaining function, modifying and compensating for this orthopedic condition that's not going to come to full recovery and they're not going to return to prior level of function. Okay. Also, even though I said we're talking from the framework of, in this lecture, about orthopedic conditions that just sort of happen in and of themselves and outside of central nervous system diagnoses, oftentimes people that do have CNS disorders end up with orthopedic injuries. So CNS disorders are spinal cord disorders or brain disorders like stroke, traumatic brain injury, spinal cord injury. Okay. So if somebody has a spinal cord injury and needs to use a wheelchair, can you think of an orthopedic injury that may happen now that they are using a wheelchair all day, every day for the rest of their life, pushing a wheelchair with their upper extremities? What could become injured? I saw some of you pushing a wheelchair in the lab last week, right, in 318. What was working really hard? Think of your upper extremities. What do you think is vulnerable? Your shoulders. Yeah, so people with spinal cord injuries that use manual wheelchairs are very high risk for rotator cuff injuries and other types of shoulder. Because they're asking their shoulders to do things that their shoulders don't normally do. Okay, good. So we do take a prevention and education approach when we're working with somebody that has a CNS diagnosis like a spinal cord injury. One of the things that we do as OTs is work with educating them and helping them prevent those shoulder injuries or those other orthopedic injuries that they're at risk for. Okay, so just to put orthopedic injuries in a big context for you from OT perspective. Impact on occupational performance changes throughout their recovery. Like we said, we intervene at different points. Who remembers biomechanical and rehab frame of reference? Somebody tell me what biomechanical frame of reference is, or what you remember of it. Yep.
It's like the, model that it's used to basically say like you trying to fix something.
And what is the something you're trying to fix from a biomechanical perspective? Yep.
More like strength and range of motion.
Yes, the musculoskeletal system, right? Great. What is the rehab frame of reference? How does biomechanical and rehab connect? They go together. Does anybody remember the rehab frame of reference? Biomechanical is the restoration of the musculoskeletal system. Rehab is the compensation piece. Okay, these are very closely connected to orthopedics and orthopedic conditions. Make sense? Everybody good? Any questions? Okay, how's that chocolate? Is it going around still? Oh, it's still sitting up here. All right, we're gonna look at a lot of x-rays. We're gonna see some bone fractures in here. Some are gonna look better than others. Just a really quick, hopefully review, right, of different kinds of bones, different kinds of bones fracture differently, right? So that's a really important thing to understand. I'm not gonna go through all of these. Hopefully, you know, this is just a refresher. Long bones like the femur or metacarpals, short bones like the carpals or tarsals, right? Those are those like square ones, basically. Flat bones like your scapula. Irregular bones that just don't fall into the other category, so we call them irregular. Do you remember, have you learned about sesamoid bones somewhere? Which is the patella. Remember that we have one in our hand down here, right here by the CMC joint. Okay, those ones don't usually fracture, but the patella can fracture. Our sesamoid bone in here is too small, not very often. Okay. The definition of fracture is a structural break in the continuity of a bone. So if somebody says to you, I broke my leg, do they have a fracture? Yes, absolutely. Whatever the person says, I broke my leg, I fractured my leg, like fracture is basically the medical term. It's the same thing as I broke. It's just when we get into classifying is where we get much more detail on what actually happened to that bone. Broke your bone, right? When somebody says, I broke my leg, and you're like, well, what bone? And they're like, well, how did you break it? Like, what happened? And they're like, I don't know. These are all the things that we know for medically when we look at the x-ray. You know that bones have some degree of elasticity or flexibility, much more when you're younger, not so much after 18, and it goes down as you get older. But in general, unless you're elderly, right, 60, 65 and older, bones tend to break like a living tree branch. Have you ever broken like a live tree branch versus like crumbling like a stick of chalk? Okay, so if you're sort of picturing a fracture happening. Cancellous bone, who knows what cancellous bone is? One. Spongy porous bone. What's a spongy porous bone? Starts with a V. Vertebrae is spongy porous. This is important. It's much more susceptible to crushing, compressive forces. So if you hear, oftentimes in the vertebrae are compression fractures, or like a crush, because they're spongy and porous. This is also important to understand from an orthopedic musculoskeletal perspective. Any fracture produces some degree of soft tissue injury, right? If there is something that happens to your body that breaks a bone, there's soft tissue covering that bone. So soft tissue injury is going to happen, whether it's very significant soft tissue injury like tendon rupture, right? Very significant, or pulling the muscle, stretching, damaging the fascia around, less complicated. But there is always some level of soft tissue injury. Okay? Cool. What bones are these? is a hand. Got here. Radius and ulna. We affectionately call this BBFF. Both bone forearm fracture. Oh man, these are really bad. I've seen both hands, that's what this is, both arms, both bone forearm fracture. So somebody falling from a pretty high height and like landing both hands. Very debilitating. In the beginning, you can't use either of your arms. So 6 million fractures happen annually. Most of them happen because of a trauma, like some kind of sudden impact. MVC is a motor vehicle crash, a fall, some kind of crush, something falling on top of you. The next most likely is overuse, like stress fractures. Any runners in here? Have you ever had a stress fracture? Or every track person has had a stress fracture in their life at this point. Running on concrete and hard surfaces, right, and end up stress fractures. And then if somebody has bone disease, osteoporosis, osteoarthritis, cancer, which some cancers can cause demineralization of bones, that can lead to fractures as well. You know the different forces, gravity, muscle contraction, and then external forces. In the context of fractures, if it's a low energy force, it leads to a low energy injury. Basically, a low amount of force can still cause a fracture, but you're going to have a more simple transverse type of fracture. And we're going to classify them more. This is a more simple fracture. Probably what you're picturing in your mind is a little crack. This one little crack that goes across the bone. That's a simple transverse. That's going to heal the best. The two segments are still sitting next to each other. Nothing's moved. There's probably, because it's a low energy, low force injury, there's probably a lot less soft tissue injury surrounding it. This healing is going to happen much better. High energy, high force fracture is going to end up with a comminuted fracture. That means there's multiple bone fragments. This is not going to heal as well. And because it's high force, there's probably much more likely more complex more complex soft tissue injuries surrounding the fracture. Okay. So who wants to tell me who raised their hand that had a fracture? Tell me what you did. Broke your fibula playing soccer. Is that a high energy force? Yes. And do you know more about your fracture? Like what it was, or tell us about your recovery.
I didn't need surgery, but it was completely snapped and splintered.
Comminuted. So when somebody says my bone was splintered, that's comminuted. Multiple fragments. Yeah.
I was on crutches for 3 months.
Longer recovery. Simple transverse, even in a weight-bearing joint, can recover in 4 to 6 weeks. 12 weeks is more complex, takes more time. Okay, again, and here's a quick review. Remember the parts of the bone, right? Metaphyseal, epiphyseal, diaphyseal. This all coming back, the end, right, the end part here. This is the metaphysis and the diaphysis, the big long part. Where the fracture happens matters, right? It's important to know along the bone. This is an example of, what bone is this? Humerus, right? It matters. Let's say somebody fractured their bone right here. Diaphyseal. This is very common, mid-humerus fracture, very common. Versus humeral head or metaphyseal. What are the differences between these two. Just anatomically. What is this one closer to? What's this humeral head? Where does this sit? Your shoulder joint. Is your shoulder joint complex? Oh, yes, it is. Very complex, right? So a fracture up here that always ends up with a soft tissue injury, much more complex recovery than a mid-humeral fracture, but this is super brownie points on a Tuesday afternoon. Does anybody remember what nerve runs down the humerus and goes behind?
Up here, is it still the axillary?
Axillary and then turns into median, ulnar, or radial. Only three. Intervasive triceps and aconius. Extensors, radial nerve. So mid-humeral fracture, high, I know, I'm total brownie points on that one, right? We'll talk more next semester about it. High incidence of radial nerve injury. Sure. Because it literally lays right across that mid-humerus there. Okay, anyway, I digress. Location is important. It's also important as an OT to understand what's happening in here. So, where did it happen on the bone? Location also means right arm, right? What side? Intra-articular, does it go into the joint and cross to the next bone? Or cross into the cartilage and cause cartilage damage, right? Intra-articular is joint, inside the joint. The extent of the fracture, did it go all the way through the bone? There are some fractures that they're called green stick, right? That don't cause two fragments. It doesn't go all the way through the bone. So that's also important to know. Is it a complete or incomplete fracture? The configuration, we're going to look at pictures in a minute. The configuration is, what does the line of the fracture look like? Transverse is horizontal. Right? Just probably what you're picturing when you hear fracture, this horizontal break. Oblique sounds like what it is, diagonal. And it's different forces that do these different things. Spiral is a twisting force, and the fracture literally spirals around the bone. Okay. And then we said comminuted is more than one fracture line, so there's more than two bone fragments. Transverse, like if you had a transverse fracture right here, we got 1, 2 bone fragments. Comminuted, more than those two, because there's multiple or splintered fracture line. The other important thing, what is it's described as a relationship of fragments to each other. What does that mean? Displaced or non-displaced? Do you know what that means?
Like whether the two ends of the broken piece are still sitting together.
Yes. Has anybody had a displaced fracture? Here. Tell me about it.
It was in my elbow.
What part of your elbow? Let's get down deep into it. What
If I'm
bone?
not mistaken, it was like right next to my electric.
Okay, so
And I almost
near the
needed
joint.
pin screws, but with my X-ray, they were able to pop it back into place.
Ooh, that sounds
Yeah, it was
cool.
really fun, which it broke another area of it,
Mhm.
but then I was just in a cast for like 2 months.
Mhm.
It was really bad.
Yes. So my wrist was my ulna, and I was skiing, and I kind of ran into a tree, broke my wrist or whatever. And this was like back in the 80s, so they did things a lot differently back then. And I went to the doctor and took it the X-ray. It was displaced, so there was a transverse fracture, not like the bones that we saw, but it was one of the fragments was shifted, and they literally were like, "This is gonna hurt." I pushed it back together. I did kind of pass out a little bit, this whole thing, but now they do surgery and they do plates and screws, and we'll talk about that in a little bit. So displaced or non-displaced is a huge factor in the healing process. They want those fragments as close together as they can be for a better healing process. between those two fragments. Another way to classify is, and not every fracture that you read, by the way, in the medical document is going to have all of these. It just depends on if it matters to that injury, but these are things you're going to see. So relationship to the external environment. What does that mean? It's like the one you don't want to picture in your head. What does that mean?
Whether or not they broke the skin.
Yes, whether one of the fragments was that displaced or not displaced? Displaced, significantly displaced enough that it has, and I love this phrase, communicated with the external. It's like the nicest way to say, hello, my bone is sticking out of my body. It's communicated with the external environment. That is an open fracture, or you might hear the term compound fracture. It's sort of the older term. Or a closed fracture, it can still be displaced, can even still be internally resting against the skin. You can see the bump, but it has not communicated. Not broken the skin, it's not communicated to the external environment, right? Open fracture is even more soft tissue injury, right? Think about all the soft tissue that bone has to literally destroy to get to the external environment. Not good. Also, if this is open to the external environment, and that's why they say that, what is this at risk for now? Infection. Right now we have an open wound and a displaced fracture and probably a ton of soft tissue injury in there. And then complications, you know, sometimes you hear it's a complicated fracture. It's super vague. It just means there's like a lot of other things going on in there. Versus uncomplicated, not a lot of other things going on, such as other soft tissue injury, nerve injury, vascular injury, whatever. Okay, questions on those? These all make sense? Again, you'll hear variations of these classifications depending on what actually happened, right? My ankle injury was not that complicated. It was just like, yeah, it was my malleolus. It's actually an avulsion injury where the tendon pulled and just like popped a little bit of bone off, and but not super complicated. So I didn't say all. Certainly wasn't communicating with the external. Thank goodness. Okay, so here's the picture. Right, what bone is this? Hopefully this is easy. Femur, right? So this is just the easiest one to see it on because it's the longest bone, so you can really look at it. The most uncomplicated injury is here, right? It's very transverse, non-displaced, mid-femur fracture. They're still close together, healing hopefully very minimal soft tissue injury. Healing will be pretty good. Oh no, this is the one that we don't want to picture. This is the one, hello, external environment, whatever, however you want to think about it. This is going to be the worst, most complicated, most difficult. This will involve surgery and plates and screws and soft tissue injury and maybe a femoral nerve injury and like all kinds of things, right? Just imagine all the things. Remember seeing all that stuff in that leg? And this bone is just like plowing through it all. Okay, here's your oblique, your diagonal. That's what a displaced, this is also displaced, but external environment, displaced internal. Okay, but in an oblique fashion. Here's an example of comminuted multiple fractures, fragments. Okay, very different healing than this. This is a segment, we didn't talk about that one, but if there's two fracture sites in one segment, this is the avulse. This is the one that I said that happened to my malleolus. And there's a spiral. You can't see the backside, but this should continue down over here and continue down the backside. And there's that green stick. That's the one that's not all the way through. This is incomplete. Remember, there's the complete and then complete here, incomplete here. Okay, good, awesome. Let's try it. Fun, BBFF. Both bone and forearm fracture again. So get with a partner, go through each of those ways of classifying, go back through those two slides and give it a try. This, I can orient you to quickly to the X-ray. What bone is this? Radius, ulna. This is the soft tissue. This is this is the skin here. See this very faded other side of the skin here. If you're trying to look and see if it's communicating with the external environment or not. This is where the skin is. Okay, same thing here. Okay, just take a couple minutes and try to classify. Sorry. I'm on slide 11. Actually, no. It's a different volume. Oh, yeah. I think I have that for. Can you answer? We're trying to read this. Yeah. Like the radius of it. I think transverse. Or opening. Yep. Yeah. Also, like, you can see it's just Okay, one more minute and we'll see what we got.
Especially in the side view, it looks diagonal.
Yeah.
I think it's just
There we go. Would you usually be able to tell someone, or would you have to like look at it, something else to be able to tell for uncomplicated and complicated since it's fake?
I mean, you can make assumptions from the X-ray, whether you think there's other complications that happen because of the severity of the fracture. But yeah, like to really look at soft tissue injury and like an app. It looks like it's poking. Yeah, it's like, I keep saying, does this make you like? Okay. Okay, let's get back together. I'm just gonna pop back here. And start from the top here. Okay, so somebody tell me the location site. Well, yeah, it's definitely in the forearm. You probably call the forearm and it's both bilateral, right? It's both sides, but on the bone here.
Oh, it was in the diaphysis.
Yes, we got diaphysis. Everybody agree? Yeah. You might say it's a little bit, it's not like mid forearm, not mid radius or mid ulna, it's a little bit sort of distal, but not quite into the metaphysics. Excellent. Isn't it complete or incomplete? They're all complete. Configuration. What do you think? Look back at it. It's okay. Take a shot. Somebody else tell me, yeah.
Oblique.
Yeah, tell me why oblique.
From the side view, it looks like diagonal.
Yeah, there is some obliquity here. Now, depending on the radiologist, you know, they may be like, transverse, transverse, or they may be like, yep, there is some obliqueness. I mean, it's not like steadfast, right? There is a little bit of diagonal there. There's also 4 bones that we're looking at, right? So one might be a little more oblique and one might be, this one is looking fairly transverse on this side. Right? Non-displaced or displaced. Significantly displaced or not? I'm just asking, qualify it. What do you think? It's pretty significant, right? So there is actual, and we didn't talk about this, there's actual shortening, right? So this is clearly this very fast velocity compressive force that just fractured, some obliquity, slid out, displaced, and moved down. Pretty significant. Not that one yet. Closed or open? Closed. It's pretty close though, right? It's pretty close. Pretty close to being open. And just a guess, do you think there's complications or not? Yes, right? So it's thinking about again, what is in your forearm? In that tiny little forearm space? A lot of stuff, a lot of muscles, a lot of nerves, a lot of vascularization, a lot of things happening in there, a lot of fascia. This is somebody, just to put it in context, this is somebody that would be extremely concerned about, oh my God, what's the word that just left my brain now? I'll come back to it. But we would be really concerned about the pressure, right, from the edema, sort of crushing and squishing the nerves, squishing the vascular stuff that's going on in there. Okay. How about this one? We'll just do this one really quickly. What bone is this? Humerus. Yep. Where is the location of the fracture? I'll go back to. Yeah. Does everybody see that? Here they actually drew a little dotted line. That's just the humeral head hanging out. The rest of the bone is back here. The rest of the humerus is back here. Is it displaced? Yeah. Is it open or closed? Thankfully. Do you think this is complicated?
Yeah.
Yes, I mean, the displacement is really complicated, but what else? Remember what we talked about? Because of the location, it's near this very complicated shoulder complex. Fun fact, this is my sister's x-ray. She slipped and fell on ice in the middle of the Adirondacks all by herself. God, there's a whole thing. Displaced, she also ruptured the long end of her biceps tendon. So that would be a significant complication. Remember that long head loves to like come up right over across. So when this happened, pop the long head off. So they had to reattach, not just only like fix this, but also reattach the bicep.
How long is this already?
It's long, it's still going on. She does not, it's been 3 or 4 years now, she does not have full range of motion. Very significant. Okay. You guys are all experts at classifying fractures now. Good job. Any questions on any of those? Does everybody feel like, ooh, it hurt? Those things hurt. They're painful. Which comes to the symptoms of a fracture. This should not be surprising for anybody. Causes a lot of pain. It hurts like the dickens if you have never done it. There's a lot of swelling and edema, right? So your body brings a lot of fluid to that site. Part of that is to help in the healing process, the bone healing process, and any soft tissue injury that happens. But swelling and edema also can cause compartment syndrome. That's what I was, sorry, let me go back. This is how my brain works, people. Here, because the forearm is so small and compacted, we would be very concerned with compartment syndrome. Remember the compartments of the forearm? Gross anatomy? Because of the swelling that can happen in here, and there's no space. There's no space for the swelling to go, so it will compress on the vascular vessels, it'll press on the nerves, and if it gets bad enough, they have to open it up. Okay. So swelling is great because it brings healing properties, but also can get out of control and cause a lot of problems. Causes a deformity, even as healing happens, it creates a, we'll talk about, it creates a hematoma, a callus, a hard callus, so on. And then if there's soft tissue injury, obviously decreases your function, difficulty moving the part of the body where the fracture is. The American Academy of Orthopedic Surgeons says if you are unable to bear weight after an injury, you should get an x-ray. That is an indication of possible fracture. So you should know that as an OT, right? If your client comes in like, I fell last night and I really can't put, it's fine, it's not a big deal. I just can't put any pressure on it. You're like, you need to go and get an x-ray right now. I can't really treat you or do much further until you get this image so we know what's going on. Okay, how many types of bone healing or ossification are there? Do you know? Can you talk about this in another class? There's two. Excellent. All right, so endochondral ossification or second bone healing. This is the traditional bone healing after a fracture you're probably picturing, like in a cast, right? Where we sort of immobilize that site as best as we can and let the bones do their thing, do their healing. Even in a cast, there is still some controlled movement at the fracture site. There's some controlled movement between the fragments, even immobilized in a cast. The only time we can remove all of that movement is if we go in there and fix it internally with like the plates and the screws, and there's not controlled movement. But for a non-complicated, transverse, non-displaced fracture, those fragments are still sitting there. It's better to not go in and do surgery and just let them heal because they're sitting nice and close together. They might still have like a little bone spur, like a little bump or whatever that remodels after time. But that's like the typical healing called secondary bone healing, which is a weird thing to call it because you're like, it's sort of like what feels like primary because of what we do most of the time. But we call this primary bone healing because we go in and we push those two fragments together so there is no space between the fragments. So that's what those plates and screws do. Not only do they stabilize the fragments, like if it's displaced, they push the two, put the two fragments together, and then we basically mechanically hold them together without any space in between. And that's important for the healing. Okay, so that's primary. Primary healing, even when we talk about wounds, is when we surgically do something. Secondary healing is when we just kind of let it do its thing and keep it clean and make sense? Okay. So we're going to talk about secondary bone healing with it, which is endochondral ossification, controlled movement. This is the cast situation. We haven't gone in and done anything. We're letting it do its thing. First 3 days of any wound healing, but also for fractures, is the inflammatory phase. There is a hematoma formation, which looks like this. So here's like a sort of transverse, non-displaced. There's a little bit of space there. We haven't squashed them together from surgery. So this hematoma, blood-filled sac, is what a hematoma is. Okay, forms around the fracture site, right, between the two fragments. And this draws in white blood cells to clean everything that's going on in here and to trigger growth of new cells. the osteoblasts. Okay. So the hematoma forms, there's inflammation because your body's like, I gotta send all this stuff to this place because you need to clean it out. We need to make new bone cells and create new bone. That's what all that edema is. So some edema is good, but our body gets out of control. Our body freaks out and it's just like, send everything, red alert, red alert. It's like, that's why we need to elevate, we need to ice, we need to control the edema because our body's just like, I don't know what to do. Fight or flight, send it all. I can't make any decisions. So it's all gonna go. Okay, so inflammation happens, white blood cells come for infection and osteoclasts clean out the dead tissue. Then osteoblasts are the ones that come and start forming the bone matrix, new bone. Okay, good. Okay. 3 to 14 days. And this is, you know, in general, right? That doesn't mean by exactly 14 days, the reparative phase is over. This is in general, uncomplicated. Remember, this is an endochondral healing. This is an uncomplicated, non-displaced fracture, but not a whole lot else going on. The soft callus forms, right? The osteoblasts are starting to make that matrix, but it's still soft. Okay. And this is the osteogenesis continues and starts bridging the fracture site with new bone, with the new bone matrix. So that basically that hematoma starts turning into like a bony matrix, but a soft bony matrix. Soft callus. And then the reparative phase, about 14 to 40 days, is continues making the bone matrix and it becomes a hard bony callus. Now it finishes basically the matrix. I feel like I'm talking about like Neo and Keanu. Picture Keanu Reeves in there making all these little bone, new bone in there. Okay. Cartilage cells form mineral, the soft callus mineralizes, becomes a hard callus. New formation of blood vessels happen. Okay. But it's still like a bump there. So there's a hard callus, the bone's all there, it's getting vascularization from the vessels. And then this is when you can start weight bearing on it. Right? So now we move into the remodeling phase. So when it's mechanically stable with the hard callus, the remodeling changes the weave and strengthens the weave of the matrix. Get rid of all the other stuff, converts everything to compact bone, and that large callus is sort of remodeled and reduced over time. That's sort of the final phase. And that could last, depending on how complicated or whatever is going on with the fracture, depends on how long that remodeling lasts, really. Okay? Can take months or to years, and the callus fades. So anyway, here is sort of the picture. If you're like a visual person, hematoma, blood-filled sac, sounds gross. Soft callus, the beginning of the bony matrix. Picture a little Keanu in there. Oh, there's one little bone. Okay, hard callus, he's all done. And then over time, it starts to remodel and look more like the bone. Cool? Questions on that? Okay, so depending on where we are, depends on what we do as OTs. So non-operative fracture management, remember this is this primary or secondary healing? Secondary healing, why is it secondary? What does that mean? We don't go in and put it together. That's primary. Secondary is what kind of movement? Controlled movement, right? So we're talking like a cast, a splint, a shoulder immobilizer. So we sort of immobilize the area, but this is where those fragments are still separated. And there's that little bit of movement in there. Okay, So this is non-operative. That leads us to, we're not operating. So we can do a splint made by an OT, a fracture brace, a cast, or it just depends on, that's up to the ortho. That's up to the orthopedic doctor and what they want to do. Okay, and how that gets sort of mobilized. That's usually non-displaced fractures, like we said. Or if there's contraindications to surgery, if somebody can't go into surgery and get that primary healing done. Okay. Controlled movement requires monitoring. People have to follow directions. Take care of your cast. Don't put any weight on this arm. Keep it clean. Don't use it. Rest it, ice it, all of these things. Okay. Questions on secondary? Controlled movement? Wearing a cast, non-displaced, uncomplicated, 4 phases of healing. Right? Primary bone healing is when we go in and we squash them together. And there's different ways that orthopedic surgeons do that. The healing is quicker because there is no space between the bones. We don't have to do the hematoma and the soft callus and all that kind of stuff. They go right to the bony matrix. Okay, so that only happens when there's no motion between the ends of the broken bone. This happens with rods, plates, screws. Orthopedic surgeons do this more and more, and they do it way more now than they did it when I was a kid. Because it's less and less complicated and they're getting better and better at it, basically. And it's less risk. But there still is risk to surgery. Sometimes I have hardly ever seen this in my career, but they could, besides like rods and plates and screws, if it's not close enough together, they actually have like synthetic bone scaffolding. Like if the 2 parts are far away from each other, they make this like little bone matrix scaffolding. So it's still a primary healing, so we don't need the hematoma and all that kind of stuff. All right, it's kind of cool. All right, we're gonna see a couple of more gross pictures in the next slide. So the few ways that operative management can happen with intramembranous or primary bone healing, right, is percutaneous pinning. What does percutaneous mean? What do you think? Skin, right? Per meaning in the. And we'll see a picture of that. This is minimally invasive because we don't cut somebody open, put something in there and then close them up. We literally, not that I do it, I don't know, I'm saying they pierce through the skin with a pin, right? We'll see that. Kirschner wires are the most common. This happens often in really small bony areas, carpal bones, metacarpals, tarsals, metatarsals, sometimes in the distal radius when it's really close to like the scaphoid or carpal bones, where you'd have to have like tiny little miniature plates and screws and it's just not going to work, right? You're going to go for pins. Because the pins are percutaneous, they go through the skin. There's an open wound now with a pin stuck in it. So they are at risk for pin site infection. The person, either themselves or somebody has to care for the pin site so it doesn't get infected, keep it clean. Right? Open reduction internal fixation, ORIF, as we like to call it. That is when we surgically open up the area where the fracture is. In reduction, what do you think reduction means? So we open it surgically, reduction meaning putting the fragments back together. That's what reduction means. So this is for a displaced fracture. So we reduce the fracture. Basically, we want those fragments as close, right? We want them really, really close together. Then they put in internal fixation, rods, screws, plates, whatever they think they need. This is the most stable operative management for fracture is an ORIF. Okay, open reduction, internal fixation. External fixation is kind of a combination of percutaneous pinning and fixation. This is an interim. So we use external fixation only while we're waiting to go in to do an open reduction. It's as if there's too much going on, they're way too sick, they can't go to surgery, we can't open them up yet, there's a lot of swelling, or we're worried about compartment syndrome or whatever is going on. They will externally fixate it for a while and then take that out and go and do internal fixation. So here's some pictures. Here's percutaneous pins into the carpal bone. So there's some carpal fractures in here. What do you think this one is? That's right under that CNC. What's this little snuff box here? Is that what you talk about, snuff box? Scaphoid, the most common carpal bone that's fractured. Okay, so yep, they literally just stick those pins in from the outside and stabilize. Here's an external fixator of an ankle. So this is why I call it like a cross between the percutaneous pins and not quite an internal fixation. So it's fixated, but the sort of rods and all that kind of stuff is on the outside, the external environment. And then these little pins go right into the bone. So these pins are into the tibia and down here into the talar bone in the foot and into the malleus. Also gross, also pin sites that you have to take care of. Also, by the way, if you ever come across somebody that has an X-fix, once it's there, it doesn't hurt. So if you see them grab it and pull their leg, it's okay, don't freak out. It's not going anywhere, it's totally fixated. Orthopedic surgeon's fine with it, it just freaks you out a little bit. You're like, I can't watch it. And they're like, no, it's fine, I'm gonna get up. And you're like, ah. And then here's an x-ray of an ORIF. This is an olecranon intra-articular. Maybe a little bit of what you got back there, right? So surgically opened, went in, added the plates and screws. They stay in there forever. These come out, this comes out and then turns into this, or this stays in forever. Nowadays, it's usually titanium. You're wondering what it's made of. Cool? Okay, how are we doing on time? All right, let's do 5-minute break. We're good. We'll come back at 2:15. We'll finish up fractures. Limb loss is much shorter. Yeah. Some chocolate, a little more glucose, get your body moving around, wake up a little bit.
I was fine off with the mentor meeting, now my. And I was also put 4 times, you know, different things. That's how it is my over. Oh. Wow. Oh, no. She just went. Yeah, she went. But I think also part of the bother. I don't know if she was too. I didn't think it was so much. Yeah, I know it was like 30 something. But I feel bad because he went to the when I was a kid. So no hair won't grow. And every time I go eat my hair, that's why I'm calling you. Because they try to wax the stuff above it. I have to like not get like a big eye. Yeah. Like no, it's just a scar. Don't do that.
No matter what. you pick for school.
Yeah, that's.
When you ever look at it.
No, thank you. Can you tell my favorite colors? Did you know that?
Favorite color is orange.
Did you know?
I
Like,
did.
Did you even know?
I didn't know.
That's my favorite.
I will never forget.
Well, it's everywhere. Everything I own is a sport color.
And then it's a holy feather.
Yeah.
Yeah, and it's just been great, and I just like. Yeah.
Yeah.
I hate when you stop it at my night.
Yeah, we'll break up the break.
Oh, here.
For a table and something, that's for
Oh, nice.
professionals. Yeah, so that's for technicians and intro. That's semester intros and yeah.
Yeah.
Or vice versa. Tell me when you're ready. Oh, those are good. Only the rest also look like that.
Right. You want to see the-
You just leave in chat and stuff.
Oh, wait, no.
Right.
Oh, wonderful. That's even better.
Yeah.
I'm so glad it has.
Even though
Yeah.
Could never.
Yeah.
What?
It's hard to know. Well, after that one night, I did.
No, I don't.
Okay, I'm gonna go ahead and get started again, just so we can maximize our timing here. So we're gonna move forward and talk about some things that influence healing. We're gonna talk very quickly about fractures from a pediatric perspective. So we classify fractures a little bit different from a pediatric perspective, and then a little OT, and then a little bit about amputations. So all of these, I'm sure, should make sense to you. We just talked about like the character of the fracture, if they have other things going on, how old they are, presence of bone disease. Promptness of medical attention is really important, right? So that client that walks in is like, I felt, and I'm like, you can't let it in. Like, you need to get it x-rayed. First thing we have to do is identify if there's a fracture, and then we can move forward to the medical management. The longer you wait, the more complicated your recovery and treatment is. So what can happen if we don't treat it well, or if there's all these other factors happening, is malunion. So that's the picture here is where the bones kind of connect together, but it's not in a great way. So it's not unionized in a straight format or in the way that the bone was before. And this can cause a lot of chronic issues going forward, or non-union where the bones just will not heal. And non-union versus delayed union just depends on the timing of it. So delayed union is basically when it still hasn't healed, but we're still in the time frame of where it could, like up to 9 months or so. And then after that, depending on the orthopedic surgeon, depends on the timeline when they define it, 9 months to a year, but after that, it's non-union, it's not gonna happen. And you can imagine there's major issues, obviously, with non-union as well for the rest of their life. Okay, I will talk a little bit about cartilage. So the cartilage in your joints, remember we said sometimes there's intra-articular fractures that sort of extends into the joint and you can even cause damage to the cartilage. Hyaline cartilage has less ability to heal or regenerate. So this can really lead to, if it's intra-articular, can lead to arthritis, basically, as you move forward. So as it heals, it can heal by fibrous scar tissue, it doesn't heal at all. And can lead to degenerative arthritis. Fractures in adults. Honestly, adults that don't have concomitant or comorbidities are not the people that we see with fractures, right? Unless they're like super complicated fractures, like my sister's wild. But you know, like you go, like when I broke my ankle in college, I didn't go see an OT, I didn't go see a PT, got crutches, crutched around, and 6 weeks later it was fine, right? Because everything else is working okay, and just waiting for it to heal and recover, and I can figure out how to deal with the rest of things that are happening in my life. So these are, you know, typically the people that we don't see. Adults that we do see that have fractures are when they happen in traumas, both, you know, the BBFF, both bone forearm fractures, very complicated, displaced, like my sister with the bicep tendon rupture. Those are the fractures that we see when there's other things going on that are limiting their independence or their function or their recovery. And all of these things should make sense to you, right? Less common, but can be more serious. The periosteum is readily torn at the neck of the femur or the shaft of the ulna. We have, so, you know, the older you get, you know, that the slower the fracture healing is, and so on. If there is a fracture as somebody in the elderly age, like 60, 65 and over, you most likely will see PT and OT because of comorbidities, because they're much more likely to have comorbidities that are happening. They already probably have limited motion and limited independence and function, and now they have this fracture on top of whatever. And also, it's kind of like, why did the fracture happen? Most of the time in the elderly is because there's a fall, high risk for fall, decreased balance, right? So they need some intervention around that too. High incidence of morbidity and mortality. When somebody that, you know, the older they get and you fall with a fracture, the more likely you're going to get sicker and the more likely you may pass away. And then depression and isolation. First, we're relieving pain. We're adjusting to the individual patient. How were they functioning before? Immobilization is still best. They might have more stiff joints. They have poor tolerance to immobilization. Like if you lay in bed for a week, like, has anybody been sick and you like lay in bed for really good? Oh, and you're sick, you know, you're kind of tired, but you get back to it pretty quick. Like up, you know, past 65, you lay in bed for a week. It's like months. Would you mind closing? It's like months. Somebody's having a party us. Much more longer recovery. So much more involvement of OT and PT. Okay. So here's a ulnar fracture here. Also had an ulnar fracture, big difference in the recovery. But after the age of 35, 40, osteoblasts are less active than osteoclasts. Okay, osteoblasts are the ones that make the bones. Osteoclasts are the ones that come and take the dead tissue away. And then there's an imbalance of deposition and resorption. So, you know, bone healing in and of itself is not as, there's much more deformity that happens after a fracture. Okay, fractures in children also happen, but not as often because they're more bendy and elastic bones. They're closer to the ground when they fall, so there's less force. They're not as heavy as they fall, and well, they heal more quickly. But as they get older, the risk gets higher. The big thing is when it's around the growth plate with kids, and it can then impact the growth and development of their bones. It's the last area of the bone to fuse, so it's vulnerable for fracture in the growth plate as well. So just a reminder, here's the little growth plate here. Here's one that hasn't fused in a little kiddo. Okay, so the way that we classify pediatric, I mean, we still want to know where it is, but when it's down here near the growth plate, we use Salter-Harris. But we also want to know, is it displaced? Is it all the other things we talked about? But this is very specific to the growth plate. Okay, so Salter-Harris is the person that came up with it, and somebody came up with this mnemonic, whether it helps you or not, related to Salter, meaning how we classify it. So level 1 is related to S in Salter, which means a separated growth plate. So here's the growth plate, but you can see that it's widened. So that's a pull force, a straight pull force. So the growth plate has widened. So Salter-Harris classification 1 is S, separated growth plate. Maybe it helps. 2 is above the growth plate, SA, above the growth plate. See that little fracture there. 3 is L, below. I think they mean the L in the below, or below the growth plate. 4 is T for through the growth plate. This is pretty significant, through the growth plate. And then the ER of Salter is erasure, which means compression. So you can see the growth plate here is smaller. So this is a compressive force that pushed the plate smaller. So this is just, again, a different way to categorize when there is a fracture around the epiphyseal plate or the growth plate for pediatrics. And, tells us prognosis. This better, this not so much. There's it, it's in words for you. Okay, in general, just a really quick review, medical management of a fracture is recognition. That's the American Academy of Orthopedics. It says if you can't put weight on it, you need to have an x-ray. If you don't have an x-ray, we can't tell if you have a fracture or not. We have to identify it first. Then we have to reduce it if it needs reduction, meaning if there are fragments, we need to get them either reduced where they're closer together, or we don't reduce them because they are where they should be, and then retain the reduction. So retention is in secondary bone healing, which is what? A cast. So retention in secondary bone healing is immobilization through something external, cast, a splint, immobilizer, whatever. And primary bone healing, it is, and remember the final one that lasts forever, ORIF, which means what? Oh, what's the O? We gotta open them up first. The R means subduction, and then how do we retain it with a IF? Internal fixation. There's also the X-fix, which is temporary. We also do the percutaneous pinning, which also comes out. Right? And then rehab. Recovery. Okay, what do? Obviously, we take a look at some of the sort of performance skills or impairment levels of things that are happening for people, range of motion, strength, endurance, pain management. We're going to talk about how to assess and intervene in all of these categories in orthopedics next semester. But our biggest focus is, as OTs, how does this impact all of these things over here? Right? How does this limit their occupation? ADLs, IADLs, and depending on their recovery, like we said in the beginning, they're gonna be more impacted than as they move along. What are the two frames of reference that we focus on in orthopedics? Biomechanical, which is restoration, and rehab, which is compensation and modifying. Okay, so we have to consider the environment that they're in at every level and how that environment limits their ability to do the things that they need to do as well, right? Thinking about those people that have worn sling, right? That is an immobilized. That's what we do for shoulder, like humeral fractures. There's no cast that we can put on there. We do shoulder immobilizer. How did that impact your function? And, you know, our ways to recover. Okay, so I'm going to skip over this. This is just one to sort of take a look at. This was the olecranon, the ORIF that we saw before. This is sort of what happened. This is an elderly person, right, who is going to have a lot of limitations because of this ORIF and this fracture. They have been in a sling, non-weight bearing. That's what the NWB means, put no weight on it, and immobilized. So their whole extremity has been immobilized. This is sort of the point that I wanted to get to. And we can talk a lot about more of these things, but their whole extremity, think about that sling that maybe some of you hear, their whole extremity has been like this for 7 weeks. For somebody who's elderly, already stiff and already has a hard time moving around. How do you think that's going to impact their right-handed, right elbow? We can take that sling off now because they came to see us at 7 weeks. What's going to happen? What's going on with this arm? Super, way stiff, way stiffer, way more painful, much more difficult to overcome range of motion and mobility and use and lifting things and weight and external forces than if it was off. So longer recovery. That was sort of the point of that. Okay, osteoarthritis, just throw it in there. It's a general term of joint pain, swelling, and stiffness. It happens over time as we age. It's the wear and tear, essentially, of our joints as we get older, and it results in pain, stiffness, and swelling that decreases function. Management from a medical perspective is RICE. I mean, you know what RICE is? For people, rest, ice, compression, and elevation. Or mice, depending on the pain level. What can you guess what mice is? I think it's cute. So R is rest, M is move, but ice, compress, and elevate. Medications like NSAID, surgery, that's where we talk about hip replacements and joint replacements next semester. Role of OT is joint protection. You know what that is? When somebody has arthritis in a joint, we want them to avoid the wear and tear. So we work with them in avoiding wear and tear. Okay. And conservation. This is a split for the CMC joint osteoarthritis. So we stabilize the joint. So there's less movement, less wear and tear when you're using that joint. And then compensatory techniques. Okay. All right. Questions about fractures? All right, I'm going to talk about limb loss. I got about 15 minutes and you guys are going to talk about a case study. So we're going to talk way more about limb loss next semester. Again, this is an introduction to limb loss. And we call it limb loss because amputation actually means like when we remove an extremity, but some people are born with congenital limb loss. So limb loss is really a better term than amputation. So as I said, two types. Congenital limb loss, when extremities are not formed in utero, and then traumatic limb loss when somebody had a limb and something happened and it was removed in a traumatic way or in a surgical way. There is obviously upper extremity and lower extremity amputation, and depending on where you work and the population that you're working with depends on sort of your perspective and how you're working with amputations. So congenital limb loss, again, is agenesis, or that extremity did not grow in utero, or there was something that happened in utero that cause the malformation of some part of the extremity. And I've seen all the way from, fingers to, all the way up to the shoulder joint. It just depends on sort of what happened in there. In the context of congenital limb loss, it says that they are born with this, they are going to develop and live their life with this sort of limb loss. So initially, where things go with this limb loss depends on the parents. It's all driven by the parents because the kids, they're the baby, they don't know. This is just what they have and that's what they're doing, right? So it's really driven by the parents. The parents are, going through sort of oftentimes through a grief process, guilt process. What did I do wrong? Why did this happen? What is our life going to look like moving forward? And then adapting to whatever is happening with the limb loss, and then deciding if they're going to do a prosthesis or not. And there's a lot of questions around that, but it's all driven by the parents at this point. So what do we do if you're working with a little one in early intervention or in the school system? Probably really early intervention at this point with congenital limb loss is helping the parents decide, right? Supporting them in their decision. Are you going to do a prosthesis? Are you not? How are we going to facilitate developmental goals? With the limb loss, if they do want a prosthesis, are you, in a place where you would be trialing prostheses with them, but still facilitating those developmental milestones with or without prosthetic, and then supporting the parents, family, and the child through different stages. Traumatic amputation happens sometimes with a compound fracture. Hello, open fracture, communicating with the external environment. Often, sometimes when there's a union or male union of recovery from a fracture, sometimes the result is an amputation, a surgical amputation. Penetrating wound to whatever extremity with significant vessel damage where there is loss of vascularization to the distal part of the extremity and it becomes necrotic. And that needs to be removed. Burns and frostbite can often lead to surgical amputations or traumatic amputations, explosions and things like that. So incidence of traumatic upper extremity amputations peaks around 20 to 40. Those are those high risk ages, by the way. That's why. Nearly 90% result from trauma. It's usually right more than left because there's more right-hand dominant people out in the world than left. And it's usually 4 times more likely to be male versus female. However, in general, 45% of amputations that are not congenital are traumatic. 55% are because of vascular disease, peripheral vascular disease. So not a trauma hasn't happened. It's a chronic peripheral vascular disease where there's less and less and less vascularization to the distal extremity. It gets to a point that results in necrotic or death in the distal extremity and they have to amputate. 2 million individuals live with amputations, about 185 per year. People of color are 4 times more likely to have an amputation because of vascular disease. 60 to 80% involve digits. And then the next most often is lower extremities for vascular disease issues. This is just a quick overview of peripheral vascular disease if you want to take a look. Okay, amputation levels. This is how we classify amputations in the lower extremity. The reference point is the knee. In the upper extremity, the reference point is the elbow. Okay. Now for the lower extremity, we can go all the way up and do a hip disarticulation. That they don't cut through the bone, they cut through the joint. So that's what a disarticulation is. They remove the joint, or one side of the joint basically, and take the whole thing. You can also have a transfemoral or above knee amputation. You can have a knee disarticulation. Again, they don't cut through the bone here. They do cut through the bone, transfemoral, obviously. Transtibial or below the knee. You can have an ankle disarticulation, I don't see that very often, and then various levels of foot, toe, foot amputations. Okay? In the lower extremity amputations, the most I see is below the knee and above the knee from peripheral vascular disease. Upper extremity amputation levels, you can take the whole 4/4. You take the scapula and the entire arm. Okay, this I've seen in cancer or traumatic like explosions. Just like we're taking the whole thing. You can disarticulate the shoulder, just like the leg, transhumeral or above the elbow, disarticulate the elbow, transradial, but includes the ulna or below the elbow, disarticulate the wrist, and like various digit amputations. Okay, so the more you take, the less you have, the less function and the less use, basically, right? Take a couple of fingers, you still got the whole arm. Disarticulate, you have no arm at all. Yep, so I just said that. Disarticulate, I said that. I already said those. Here are all the people that are involved in traumatic and surgical, like peripheral vascular disease. OT, PT, this is respiratory therapy, this is social work. Everything else you should know. So how does the surgeon decide where to amputate? This is a very complex vascular surgeon, very in conjunction with an orthopedic surgeon, very complicated decision. It depends on the vascular supply. They have to have the best vascular supply at the lowest level they can find. They want to preserve as much of the extremity as they can, but they still have to have good skin coverage and the vascular supply and nerve supply. The goal is to preserve as much as possible. Sometimes they, sounds gross, but they take a little, doesn't work, they take a little more, right? Because they want to be really conservative. They want to take the least amount that they need to. Primary closure, right here's a typical closure. These are typical closures for surgical or traumatic amputation. This is just where you pull the skin over, skin flap over the end. This is if they need to come in and do a whole muscle flap. That's where things get complicated. So what do? Obviously compensatory techniques. Depending on how much you're missing in your upper extremity or your lower extremity, maintaining range of motion of the joints that are still there, maintaining strength of the joints that are still there, preventing contractures of the joints that are still there, conditioning the residual limb if they want a prosthesis. That residual, there's things that we have to do to get that limb ready to receive a prosthesis. It's a whole different level that we're not really going to too much today. Postural awareness, their posture changes, their core changes, their center of gravity changes. If you remove part of your body, your center of gravity changes. They might need to change their dominance, right? If it's their dominant upper extremity that is removed. And then again, upper extremity prosthetic training. There is one OT in this community that does upper extremity prosthetic training and she's at outpatient at Clinton Crossing. She's going to come next semester and talk to you guys about what that's like. All of these things you should know about client factors, function, sensation of the residual limb. You've probably also heard of phantom sensation and phantom pain. There's a lot of different interventions that we can do around phantom sensation, which is different tactile sensations that you feel outside of pain that you're like, oh, my toe itches. The toe's not there anymore. Versus pain. Appearance and self-image is really important to people. The psychosocial effects, obviously, and really sort of helping people take the perspective of that things have changed in how they do things, but they can still do the things that they did before. It's just going to be different, a different way that they do it. That's my puppy. That's Luke, but we only call him Puppy. His name is Luke, but for whatever reason, Puppy has always stuck. He's 6 years old and we still call him Puppy. So yeah, so more to come. I'll be here on Thursday to talk about burns. assessment and intervention next semester. Looking forward to the fall. Does anybody have any questions? I know that is like a really quick overview of amputations, but like I said, we really delve very deep into assessment and intervention in amputations, so I didn't want to go into too far in this semester. Questions about fractures, questions about amputations, or limb loss, OT's role. Most of the time, in most settings where you will see amputations is lower extremity amputations, by the way. They are way more common than upper extremity amputations. Most peripheral vascular disease happens in the lower extremity. If you do see upper extremity amputations, it's most likely from a traumatic injury. Like I have seen frostbite, I've seen exploding car accidents for upper extremity amputations. I've seen, like I saw a really horrible ATE accident, someone their arm got semi-ripped off and I had to take it off. I've seen work accidents of like crush injuries, but those are not that common. That's why we have like one OT in the community that does upper extremity prosthesis. Most of the time it's going to be lower extremity. The prosthetic part for lower extremity and the training is really PT's purview, but our purview is you gotta know how to function in your life with this prosthesis. You need to know how to get it on and off as part of your ADLs, the things that you do when you function in your life. So we do need to also have a level of understanding of prosthesis as well. Cool. Okay, I think you're going to talk about a case study for the last couple of minutes, and I will see you on Thursday. Thank you.
Thank you. Thank you.
Do you want me to leave a recording for this?
Yeah, that would be great. And then I'll just
End it and it's going to the cloud. Okay. We don't have to do anything. We just, if you go into Zoom and then just stop record, okay, and then close it all out.
Thanks.
So it'll be all good. Thank you.
Look at it. I can reach this. Bye.
If it starts to go along with it.
I don't know how to make it.
Right now.
But I'll make it. You burn any.
Thank you.
So as you saw in the syllabus that we talked about at the very beginning of the semester, there are 3 case studies that you're going to do throughout the semester. And one of those, the first one, is based on orthopedics. That's why I waited till today to really show you what this assignment is. It is an independent project. Do not discuss with others. I really want your own work, so we can really make sure you're understanding what's happening, and we can give feedback. So using materials, get outside references. If you use something that was from class, you don't need to reference it specifically. So don't necessarily reference our slides, things like that. But I do want you to look at other information though. Look outside of those, gather more information. And you're going to submit this in a Word document through the Dropbox, and it's all in there. And you have a couple weeks to do it. So this is the first case study. It's Cleo's a 32-year-old female following a basketball injury, and it talks about what the injury looked like, what types of things they're seeing now. And what you're going to be doing then is really looking at that from a functional standpoint, but also looking at it from what happened, what type of injury is it, what type of fracture? And in the rubric is where all the questions are. So you're literally gonna go through each of these questions that are stated on this rubric. So based on the symptoms and experience, what do you think the diagnosis is and why? And really focus on that why. What was it that led you to that type of diagnosis? What diagnostic tools would be used, or medical team, or really how would you get a full diagnosis? And identifying functional skills. At least 3 functional skills to get that full point, the full points. Looking at what might be impacted and what education Cleo might need as well before being discharged, and why. What's the rationale for that? And what complications might happen, and again, the rationale. And finally, just that it's written with good grammar, with APA format. I do want this written more as an APA paper, not a personal paper. So not using I, things like this. This is really looking at a full case study. In your actual, if we go up to the top and Moodle, there is the specific case studies. The drop boxes are up here, but there's also an example there for just one. I don't believe it was an ortho, I think it was the cardiac one. Yep, so it's the cardiac one. So here is an example of one that was done. Want you to really try to follow that format for a full paper. What is that? And again, the Dropbox is up in here. Does anyone have any questions on this assignment? If there are no questions, you can go. On Thursday, Dr. Kunich will be in here again. We'll follow the same type of format. She's going to be presenting the entire time. And then next week, again, just to reiterate, I will not be here. On Tuesday, Dr. Kunich will be in for peripheral nerves. And then for Thursday's class is the asynchronous oncology lecture. Make sure you do it because they are included on the exam. It is open in Moodle now, so feel free to get started whenever. Let me know if you have any questions, and I'll see you tomorrow.
Two projects. Two more people.
Wow. I mean, I actually love that.